Good day, nurses. Today we're going to discuss your diuretics. Okay, pag sinabi kasi nating diuretics, no, ito yung tinatawag natin na mga gamot, okay, na pampaihi. Okay, as simple as that. Okay, because your diuretics, they usually produce, no, increased urine flow or yung tinatawag natin na diuresis by inhibiting your sodium and water reabsorption from the kidney tubules natin. Okay, that is why isa sa mga action ng ating diuretics, they usually trigger what? The excretion of your water and electrolytes from the kidneys. That is why ang ating mga diuretics, they are indicated to treat your renal diseases. Kapag nagkaroon ka ng edema, ibig sabihin nagkaroon ka ng fluid retention in your body or fluid overload. Okay, your hypertension, and of course with your heart failure natin. Kasi primarily, no, these diuretics, they actually have two main purposes. It is to decrease your BP and of course, to decrease your edema. Okay? And aside from that one, ang ating mga diuretics, meron po tayong dalawang klase. Ano yung mga yun, sir? We have your potassium-sparing and your potassium-wasting natin. Okay? Under your potassium-sparing, we have actually three. Okay, ano yung tatlong yun, sir? We have your amiloride, we have your spironolactone, and of course, we have your triamterene na tinatawag. And under your potassium wasting, we also have three. Okay, first, we have your thiazide diuretics, your loop, and of course, we also have your tinatawag na osmotic diuretics natin. Okay, let's start first with your potassium-sparing diuretics natin. Pag sinabi natin potassium-sparing diuretics class, they are also referred as what? They are also referred as your aldosterone inhibiting diuretics. Your aldosterone inhibiting diuretics, wherein, alam naman natin nun, ang action ng ating aldosterone is to retain your sodium, no, in water and excretion of your potassium. Yun po ang action ng ating aldosterone. Pinopromote po niya ang retention ng ating sodium in your water and pinopromote niya ang excretion of your potassium. Ngayon, sabi natin, aldosterone inhibiting diuretics, ini-inhibit natin yung action ng ating aldosterone. Therefore, magkakaroon ng blocking of your aldosterone action wherein it will inhibit our sodium and potassium pump. Ang nangyayari na ngayon, kabaliktaran na po, lalabas ang ating sodium, papasok naman po ang ating kidney. That is why, sinabi natin, ang ating potassium-sparing diuretics, they are aldosterone inhibiting diuretics. Or ibig sabihin, pag potassium sparing, nire-retain po nila ang ating potassium. Excreted ang sodium, excreted ang water, but your potassium will stay in. Okay? Ngayon, sa ating tatlong klaseng potassium-sparing diuretics, ang pag-aaralan lang po natin is your spironolactone. Okay, number one. Okay, your spironolactone, they usually acts on your late distal, okay, tubules and your collecting ducts. Tandaan natin tas ha, yung ating mga diuretics kasi, okay, alam naman natin na most of your sodium and water reabsorption occurs throughout your renal tubular segments, di ba? Meron tayong mga proximal convoluted tubules, your loop of Henle, ano pa, your distal, mga ganyan, and your collecting ducts natin, they are the segments of your, sa kidney natin, kidney tubules natin, okay, or your renal tubules natin. Usually, your diuretics kasi, they can actually affect, no, some of your segments or more segments of your renal tubules. Okay? So, ngayon dito, ang ginagawa kasi ng spironolactone natin, they act on your distal tubules and collecting ducts natin, wherein nagkakaroon pa ng excretion of your sodium, your water, your bicarbonate, your calcium, but, tandaan niyo ito, retains your potassium, kaya nga sinabi natin siyang potassium-sparing diuretics. Okay? Ngayon, ang ating mga indications, okay, kanina po indicated itong potassium-sparing diuretics natin, specifically your spironolactone. Number one, your patients with edema, patients with diuretic-induced hypokalemia in patients with heart failure, your liver cirrhosis, nagkakaroon kasi ng ascites yan, okay, or accumulation of your fluid sa ating sa ating tawag dito, nakalimutan ko to rin, peritoneal cavity. Okay, peritoneal cavity natin. Aside from that one, your nephrotic syndrome, your heart failure, your hypertension, and of course, your hyperaldosteronism. Okay? And then, tandaan ninyo, no, that there are actually adverse reactions of this potassium-sparing diuretics. Sabi natin, potassium-sparing, nire-retain natin ang ating kidney, ang ating potassium. Therefore, it will result to what? Hyperkalemia. Okay? Magkakaroon ng maraming or mataas na serum level of your potassium inside our body dahil nga in the first place, your potassium-sparing diuretics, nire-retain nila ang ating potassium. Okay? And aside from that one, it can also result to dizziness and headache natin. Sir, paano na po natin ma-determine yung ating paano po natin ma-determine na si patient nagkakaroon na po ng hyperkalemia or any tawag dito, imbalances in your potassium. Tandaan natin, may it be hypokalemia man yan or hyperkalemia once si patient nag-develop ng muscle weakness. Yan kasi yung isa sa mga na-overlook na symptoms or signs ng ating hyper or hypokalemia natin. Okay? And aside from that one, what will be our nursing considerations natin when we are going to administer your potassium sparing diuretics natin? Of course, number one, you have to monitor your what? Monitor your intake and output natin. Okay? I-monitor dapat natin yung intake and output natin, closely monitoring. So, dapat yung ating dapat, di ba, ang normal na ng urine output natin at is 30 ml per hour. Once si patient nagkaroon ng less than 30 ml per hour or possibly less than 600 ml per day, we have to report this one. Kasi nga hindi na po siya normal. Okay, nagkaroon po ng masyadong mababang, tawag dito, output ang ating patient. Wherein, sabi natin diuretics, pampaihi yan. So, dapat, normally, medyo mas madami dapat or dapat meron siyang nai-excrete na urine. Okay? And aside from that one, of course, you have to monitor also your vital signs, no? For us to have your baseline data. And then, you have to monitor for hyperkalemia. Sabi natin, kapag si patient nagkaroon ng hyperkalemia or hypokalemia man yan, it's either, ang number one kasi na isa sa mga na-overlook natin, sabi natin kanina na sign is your muscle weakness natin. And tandaan natin, klasa, since sabi natin diuretics to, nagkukos to ng diuresis, ihi ng ihi. Therefore, kailan natin mas ideal na i-administer tong gamot na to? Dapat ba sa gabi? Or dapat mas prefer natin na mas maganda pag umaga? Definitely, mas magandang i-admin natin to or i-administer natin to in the morning. Gets natin? Kasi nga, imagine mo pag gabi mong i-administer ang ating diuretics natin in general, ihi ng ihi si patient. Of course, hindi na po yan makakatulog. Magkakaroon siya ng disturbed sleep pattern. Okay? So, aside from that one, of course, yung diet natin, klaseng diet natin, kailangan natin instruct yung patient natin. Ano dapat yung kailangan niyang i-avoid? Definitely, mga pagkain na mataas ang potassium level serum niya or food. O mga potassium-rich foods natin, kailangan nating i-avoid yan kay patient. Okay? And aside from that one, nakalagay din dito yung ating mga drug-to-drug interactions. So, number one, okay, your potassium supplements and inhibitors. Bakit kailangan nating i-avoid na si patient magkaroon ng or mag-take ng potassium supplements natin? It's because, okay, sabi natin, no, it will increase your risk to develop hyperkalemia. Kasi in the first place, your potassium-sparing diuretics, nagre-retain po sila ng potassium. And aside from that one, kapag sinabayan natin yan ng NSAID while your patient is taking your potassium-sparing diuretics, of course, magdi-decrease po ang kanyang effect. And aside from that one, pag kinag-combine mo ang ating spironolactone plus your digoxin, sabi natin si patient kapag nagkaroon kasi ng ng hypokalemia or hyperkalemia or nagkaroon ng potassium imbalances, automatically pwede siyang mag-develop ng digoxin toxicity. And of course, with your lithium, kapag pinag-combine natin ang ating potassium-sparing diuretics plus your lithium, it will also lead to lithium toxicity. Okay, so that's it for your potassium-sparing diuretics. That's was it again. Also, with your potassium wasting naman pa tayo. First, we have your thiazide diuretics natin. Okay, your thiazide diuretics, meron kasing dalawang klase yan. Meron tayong thiazide and of course also your thiazide-like diuretics natin. Under your thiazide, we have your bendroflumethiazide, your chlorothiazide, your hydrochlorothiazide, your methylchlorothiazide, and also your polythiazide natin. On the other hand, for your thiazide-like diuretics, we have your chlorthalidone, indapamide, and your metolazone na tinatawag natin. Okay? So, your thiazide diuretics class, they are actually derived from your sulfonamides. Okay? And they are indicated for patient with edema, and also to prevent development and recurrence of your renal calculi or yung mga bato-bato natin sa kidney. Okay, yung mga kidney stones natin or yung tinatawag natin yung urolithiasis or urolithiasis. And of course, to decrease your blood pressure and of course, to treat your heart failures. Tandaan natin na yung thiazide kasi na, yung thiazide diuretics natin, no, they are actually one of the first diuretics na na-invent. Okay, particularly your chlorothiazide natin. Okay, it was actually the first thiazide, no? And also your hydrochlorothiazide naman ang sumunod after your chlorothiazide natin. Okay, so your thiazide diuretics, saan po sila? What part of your renal segments, renal tubular segments nag-act? They usually acts on your distal tubules naman po. Okay, they increase the excretion of your sodium and your water in your distal tubules natin. And tandaan natin, test pag thiazide diuretics yan, they are being used for long-term. Okay, long-term treatment of your hypertension natin. So, what are the different adverse effects when your patient is taking your thiazide diuretics? Number 1, okay, adverse reaction, we have here reduced blood volume, of course, your orthostatic hypotension or your postural hypotension, hypokalemia, kasi sabi natin, potassium wasting naman po yan. Ang ginagawa po kasi naman potassium wasting natin, lahat, your sodium, your potassium, your water, and other electrolytes, ni-excrete po lahat ng yan. And of course, possible hyperglycemia, and your hyponatremia, ibig sabihin masyadong mababa ang ating sodium or serum level of your sodium in your body. Okay, tandaan natin tas ha, that your thiazide diuretics, sabi natin kanina, they usually derive from your sulfonamides. Therefore, eto, tandaan niyo to class ha, kapag si patient meron siyang sulfa allergy, okay, we have to be cautious when you are going to give your thiazide diuretics kasi pwedeng magkaroon siya ng hypersensitivity reactions from your thiazide diuretics natin. So, that's it for your thiazide diuretics naman po. Let's proceed with your loop diuretics naman po. So, your loop diuretics, no? Okay, your loop diuretics, isa siya sa pinaka-potent, no, na diuretics natin. They are the most potent diuretics kasi nga, these diuretics, they have the greatest volume of diuresis. Sila yung may pinakamadaming, volume ng pwedeng iihi ng pasyente natin. Okay, anong mga example ng loop diuretics natin? We have here, your bumetadine, your etacrinic acid, at a very common, your furosemide and your torsemide na tinatawag natin. Ang ginagawa ng ating loop diuretics naman, class, they usually decrease the reabsorption of your sodium and calcium in the ascending loop of Henle naman po. Class, baka malito kayo na pag sinabi kasi natin yung reabsorption, ibig sabihin, binabalik po natin yan pabalik sa ating system or sa ating circulation or sa ating blood circulation. Okay, yun pang ibig sabihin ng reabsorption natin. Ngayon, okay, pag dinikrease natin ang reabsorption of your sodium and chloride in your ascending loop of Henle, nagkakaroon po ng increased renal excretion of your sodium, your chloride, your water, and also your potassium natin. Okay, kanina po indicated yung ating mga loop diuretics. They are usually indicated for patients with acute pulmonary edema, or nagkaroon siya ng pulmonary congestion, or edema in general, and of course, for patients with hypertension natin. Okay? So, tandaan natin, class, yung ating mga loop diuretics, of course, may kaakibat yan ng mga contraindications. Okay? Or, mga complications natin, I should say. Number 1, of course, hypokalemia. Sir, bakit hypokalemia? Sir, kasi nga sabi natin, your loop diuretics is under your what? Potassium wasting, ibig sabihin lahat, sodium, water, chloride, bicarbonate, potassium na ilalabas po or being excreted by your kidneys. Okay? So, ano ba ulit yung normal values of our potassium? It's 3.5 to 5 mg per liter. Kasi kailangan nyo maging particular sa mga lab results natin or lab values natin para ma-determine natin, para makapag-obtain tayo ng baseline data if we can give your diuretics or this type of medication or we're going to withhold it. Okay? And of course, your loop diuretics kasi class, it can actually cause ototoxicity. Kasi ano ba yung mga sign and symptoms ng ating ototoxicity? Number 1, kapag si patient nagkaroon ng tinnitus or tinnitus and of course possible hearing loss, automatically si patients nagkaroon na or nagka-develop na ng ototoxicity from taking your loop diuretics. Tandaan niyo class ha, if you're going to give your loop diuretics or for your furosemide, okay, your furosemide kasi meron yan sa e-cart natin, no? Okay, or emergency cart natin, they are being administered via IV push kasi yan. Okay, tandaan niyo to class ha, IV push po ang ating furosemide. Ngayon, kapag masyadong rapid or mabilis yung pag-push natin ng ating furosemide via IV, okay, less than 1 minute yung pag-push natin, possible si patient magka-develop ng ototoxicity. Sir, ano din po yung normal time dapat ng pag-push natin ng ating IV na furosemide? Dapat more than 2 to 3 minutes. Dapat matagal po yan. Kasi si patient, pag masyado mabilis or very rapid yung pag-push natin ng ating furosemide, pwede siyang mag-develop ng ototoxicity. And then, tandaan niyo ito, class. Any potassium imbalances kasi, no, this electrolyte kasi very, very crucial, no. Pag nagkaroon kasi si patient ng hypokalemia, it can actually trigger arrhythmias. Yun yung iniiwasan natin. It can actually trigger arrhythmias. Or magkakaroon siya ng problem sa kanyang rhythm of his or her heart. Okay? Ano yung mga ating, ano yung mga, tawag dito, mga nursing responsibilities natin when you are going to give your, loop diuretics? Number 1, you have to monitor for your potassium. Of course, si patient, we have to instruct them to have at least potassium supplements. Okay? Monitor for their excessive diuresis. Baka masyadong madami. Sabi natin, ito yung pinaka-potent na diuretics natin because it produces your greatest volume of your diuresis. And of course, you have to monitor your and record your patient's INO, okay, or your input and output, as well as their weight. Okay, sir, paano po tayo mag-monitor ng weight natin? Dapat, if you're going to monitor the weight of patient accurately and appropriately, dapat same clothing po dapat yan. Okay, same clothing and same scale po ang ating gamitin. Okay, and aside from that one, you have to administer also these diuretics in the morning, para may iwasan natin yung disturbances under sleep pattern natin. Okay? So, that's it for your loop diuretics natin. Let's proceed with your osmotic diuretics naman po. Okay, your osmotic diuretics naman po, class. A good example of this one is your what? Your mannitol and then your urea. Okay? Pag sinabi kasi nating osmotic diuretics, yan ini-increase niya po kasing osmolality ng ating ng ating cells, okay, ng ating water in our body, okay, ng ating mga solutes, okay. So, ang nangyayari po dito, class, it increases your osmotic pressure within the kidney through your glomerular filtrate na tinatawag natin. So, ano bang ibig sabihin ng osmosis natin or osmotic? That is the moving of your fluid, no, into your extracellular spaces. Okay, that is the moving of your fluid into your extracellular spaces. Pag oncotic naman po yun, it draws your water inside your cells. Magkabaliktad po ang osmotic and your oncotic. Okay, magkaiba po yung dalawang yan. Ngayon, pag na-increase natin yung osmotic pressure within your kidney through your glomerular filtrate, it will inhibit your what? The reabsorption of your sodium and your water. Okay, that is why kanino indicated ang ating osmotic diuretics. Indicated po sa mga patients na number 1. It treats your acute renal failure natin. And of course, ito, for patients with cerebral edema. Or ibig sabihin, nagkaroon ng pagtutubig sa ating part ng brain natin. That is your cerebral edema. Therefore, ang action ng ating osmotic diuretics, it can decrease your ICP or your intracranial pressure as well as your intraocular pressure natin. Sa may eyes naman po natin. Yan. Okay, what are the possible tawag dito, your adverse reactions of your mannitol or your osmotic diuretics? Number 1, pulmonary edema, class. Okay, number 1 talaga to na problem ng ating osmotic diuretics. Bakit? Bakit pa nagkakaroon ng pulmonary edema? It's because of your nagkakaroon ng pulmonary congestion and circulatory overload in our body. Okay, ngayon, ang kailangan nating tandaan, lalo pag mannitol yan, class, your mannitol is being used also to decrease your ICP, di ba? Kanina ba usually, ano ba yung mga condition na tumataas yung ICP natin? Of course, number 1 yun, pag nagkaroon siya ng problems like meningitis. For example, bacterial meningitis. Talagang tataas kasi yung intracranial pressure natin. Ibig sabihin nun, di ba, your skull and your brain, sabi natin your skull or your cranium is not elastic. Okay, hindi po sila nag-expand. Okay, ganun na po yung mismong nila, hindi na po sila lumalaki or nag-expand. And then kapag masyadong nagkakaroon ng mataas na intracranial pressure, nagkakaroon ng dumidikit yung ating yung mismong part ng brain natin sa ating cranium. Yun yung tinatawag natin na Born-Merkelly parang theory natin na hindi nag-expand yung ating or hindi nag-adjust yung ating cranium. Okay? That is why kapag mannitol ang binigay natin, class, tandaan niyo to, no? Usually kasi nagkikristallize yan or tumitigas. That is why pag magbibigay tayo ng mannitol dun sa kanyang line, okay, kailangan natin yan mag-flush muna ng normal saline natin before giving your mannitol and then right after your mannitol. Kasi nagkakos talaga yan ng crystallization. Tandaan niyo yun. Kaya nga, possible si patient kapag naka-mannitol yan, no? Possible yan na magkaroon siya ng infiltration sa kanyang line. Okay, magkakaroon ng infiltration. Okay, so that is your osmotic diuretics natin. And of course, we also have here your carbonic anhydrase inhibitors natin. Okay? Your carbonic anhydrase inhibitors natin, usually dalawang part ng katawan natin ang inaapektuhan niya. Number 1, we have your kidneys. Okay, sorry. Also, we have your eyes natin. Okay, dito muna tayo sa mga klase ng ating carbonic anhydrase inhibitors. Of course, we have your acetazolamide and your metazolamide natin. Okay, kanina po indicated ang ating mga carbonic anhydrase inhibitors. They are indicated for patients with heart failure and also patients with glaucoma. Okay, familiar with your glaucoma? Eye disorder kasi yan, no? Your glaucoma kasi nagkakaroon niya ng ng damage to your eyes or nagkakaroon ng damage to your optic nerves. It's because of your masyadong mataas na intraocular pressure natin. Okay? So, dito sa kidneys natin, class, ang ginagawa ng ating carbonic anhydrase inhibitors, okay, dinidecrease po nila yung availability ng ating hydrogen ions na tinatawag. Wherein, these hydrogen ions kasi, class, they usually, dumutulong sila sa mismong sa reabsorption ng ating mga water, ng ating mga electrolytes in our kidneys. Therefore, kapag di-decrease natin yung mismong availability ng hydrogen ions natin, mabablock po natin yung mismong sodium hydrogen exchange mechanisms natin that will lead to increased urinary excretion of your sodium, your potassium, your bicarbonate, and also your water natin. Okay, and aside from that one, in your eyes naman po, usually ang effect pa ng carbonic anhydrase inhibitors natin, sabi natin, no, your carbonic anhydrase inhibitors, they are indicated for patients with glaucoma. Okay, bakit ano ba yung problem sa ating glaucoma, class? Ang problem kasi sa glaucoma natin, class, nagkakaroon ng abnormalities din sa mismong pagproduce ng ating or tawag dito yung parang, what do you call this one? Basta nagkakaroon ng problem mismo dun sa production ng ating aqueous humor na tinatawag. Yung aqueous humor, class, yun po yung parang tubig sa may part ng eyes natin. And sino po nagproproduce ng aqueous humor natin? It's your ciliary bodies, no? That is your ciliary bodies. Ngayon, kapag nagkaroon ng problem dun sa production ng aqueous humor natin, masyadong madami, okay? Or kapag masyadong madami, kasi of course, tataas yung pressure dun sa mismong eyes natin. Okay? That will affect your optic nerve natin because nako-compress natin yung part ng retina natin, no? Ganun kasi kapag glaucoma yan, class. Therefore, tataas yung ating intracranial pressure na tinatawag or your IOP. Ano bang normal values ng ating ng intraocular pressure natin? Of course, should be 10 to 21 millimeter per mercury. Yan po yung mismong normal na ng intraocular pressure natin. Kapag humigit yan ng 22, kailan ba tumataas yung ocular pressure natin normally kapag kakagising natin? Mataas actually yung intraocular pressure natin. Ngayon kapag in the long run masyadong mataas yung intraocular pressure natin, it's because of the decreased production or increased production of your aqueous humor by your ciliary bodies. Magkakaroon talaga ng glaucoma yan, class. And your glaucoma kasi it will lead to blindness. Okay, your glaucoma will lead to blindness. Okay, ulitin natin, nagkaroon ng problem in your production of your aqueous humor. Okay, meron kasi tayong tinatawag dyan na drainage system, no? Ngayon, kapag nagkaroon ng problem sa drainage system sa ating eyes, it will result to build up of your fluid of your aqueous humor that will compress your retina, and of course, that will also further damage your optic nerve natin. That is why magbibigay tayo ng carbonic anhydrase inhibitors para i-decrease ang ating production of your aqueous humor. And of course, pag na-decrease natin yan, marereduce po yung ating intraocular pressure na tinatawag. Okay, so what are the possible adverse reactions of your carbonic anhydrase inhibitors? Of course, hypokalemia, hematuria, melena or your dark tarry stool, possible metabolic acidosis, and of course, other electrolyte imbalances. So that's it for our discussion for your diuretics.